What's up, future respiratory therapist? Here is the first section of a multiple part series where we're going to be talking specifically mechanical ventilation, but even more specifically about waveforms. Today's message is all about the pressure waveform, but we have to talk about the flow, the volume, the flow volume loop, and the pressure volume loop, and that's all coming in the next week's time. Okay, so stay tuned for future parts to this series, but I want to break them down one by one so we can really spend time digesting what each one will tell us. Now, do me a favor. We got lots of people coming in to the profession. School's about to start up as we head into fall. I need you to share this video with as many people as you can, as many platforms as you can. Like it, comment, and subscribe if you're not already done so. Turn on the bell notifications. All you're going to get is an occasional video that might make you a better respiratory therapist. And if it doesn't, then you can unsubscribe. But I'd appreciate your subscription today. Now, pressure waveform. Let's dive in. Welcome to this video all about the pressure waveform. We're going to break this down and make it make sense for you so that when you are taking your TMC exam or just standing in front of a ventilator, you feel more confident in what you are looking at when observing waveforms. Let's look at it. Now, obviously, there's lots of different things on this screen, okay? Don't get caught up in what I'm going to make all this make sense. That's what I'm trying to say, okay? So let's just start, first of all, with the basics of the pressure waveform. We know that pressure is on the y-axis. The x-axis is time. So when a breath happens during mechanical ventilation, you see that the breath starts, and as volume goes in, pressure rises. And then, of course, exhalation happens, and we return back to our baseline. Before we jump into some of the ways to use the pressure waveform to help you be a better clinician, let's just talk about the basics of it first, okay? So as this pressure rises, we're going to come to a point here. This point is the highest pressure that is reached during the breath. This is what we call PIP. It is peak inspiratory pressure. That is what the highest point represents. Now, if we do an inspiratory hold, we have the ability to assess our patient's plateau pressures. And this is something you should be doing every single time you stand in front of a ventilator. If you want to be a good respiratory therapist, then you want to know your patient's plateau pressures, because we know that plateau pressures speak to the integrity of the alveoli, of the pulmonary parenchyma. So when we do an inspiratory hold, we see where we come down and we get this little plateau. Hence the name right there, right? So this area right here is what we call the plateau. Now from there, we let go of the inspiratory hold and we return back to baseline. Baseline is going to be referred to as PEEP. So when you look at this point here and this point here, this is positive in expiratory pressure. Now if you ever return back to zero, then you don't have any PEEP set. But in today's world, we typically always have PEEP. So we're going to look at it from this perspective. These are the main pressures that you need to be familiar with. Now, I'm going to show you one more here. Let me get rid of that plat. I'll put it back up here. This is plat right here. Mean airway pressure is everything underneath this waveform, including your PEEP measurement. So mean airway pressure, it's the average pressure over a certain amount of time. It's just like the grade book. When you look at it and you see the average of all your grades, that's your mean grade. Same thing with airway pressures. So we know we have a mean airway pressure, we have a PEEP, a plateau, and a PIP. Now here's what you need to recognize, and here's what you need to know. This is what you want to get really, really good at. If you see where the breath comes in and has a PIP up here and then a plateau that falls down to here, well, look at the difference here between these two. See how that is a big difference? This indicates airway resistance. So in other words, the larger the gap between PIP and plateau, then you know the larger the airway resistance is for your patient. This would represent a patient that maybe has asthma and they are in acute bronchospasm. That's what it would look like. You would have a high peak inspiratory pressure, but you would come down and level out to where like, oh wait, the plateaus are about the same as what they were before. And that's because asthma on its forefront, on its basis, is an airway resistance problem. It is not an alveolar or a parenchymal problem. So your alveoli stay healthy, they stay compliant, but the airway resistance causes that PIP to go up higher. Now, let's look over here at this next example here. We see where we come up and we have our PIP right here, and then our plateau is right here. Look at the difference there. It's very, very small, right? So here we have very little airway resistance. So what's causing this peak inspiratory pressure to go up? Well, that is because your alveoli are now impaired. They have become stiff. They have become non-compliant. This is what we're looking at a compliance issue. You have an alveolar problem. This would be something like pneumonia, ARDS, maybe idiopathic pulmonary fibrosis, something that causes your lungs to become very, very stiff. We see what's happening here, right? There is a difference between airway resistance problems and alveolar compliance problems. The difference is in your pressure waveform. You can assess it right there, okay? So that's the first thing you need to know. Now we're gonna look at some practice questions here in just a second, and it's gonna basically quiz your knowledge over this scenario. But before we do that, let's look down here at this next level of pressure waveforms. Now, you'll notice that there is a difference between 1 and 2. 2 is obviously very square in appearance. 1 has a slow rise to it. This is because when you look at your pressure waveform, you can distinguish between volume control breaths versus pressure control breaths because of the shape. So, with volume control, which is what number 1 is, as the volume goes in, the pressure increases slowly, gradually. So you see a slow rise to your peak inspiratory pressure. Remember, with volume control, as volume goes, pressure grows. But in pressure control, which is what we see here with illustration number 2, pressure control is a mode where pressure rises, is held, and then released. That wasn't supposed to happen. Pressure rises, is held, and then is released. So we see a square waveform. What's the takeaway, Joe? The takeaway is square pressure waveforms tells you you're in pressure control. At the very least, you're in pressure support. You'll also get a square waveform, pressure waveform with pressure support. So let's say you're in SIMV, volume control, with pressure support, then it's very likely you will get a combination of these breaths that show a slow rise to PIP with the volume control breaths, and then the pressure breaths, pressure support breaths, will be square. So you can see a mixture of these. You just have to remember pressure is square, volume is not. Now, there's one other thing we got to talk about here real quick before we break down our questions, and that is when I look at the pressure waveform, how do I know if this is a time-triggered machine breath, or how do I know if this is a patient-triggered breath? How can I differentiate the two? Here's the answer. Look here at your baseline. If you do not see a deflection, like what we see here, see that deflection right there? That dip downward? That dip downward means that the patient initiated this breath. Their diaphragm dropped, created a negative pressure, pulled pressure out of the circuit, and gave you this deflection. So this one would be a patient-initiated breath. Over here, we do not notice that dip down. So this would be a machine-initiated, time-triggered breath. We're going to talk more about time trigger and cycle and all that stuff in future videos. But for right now, you can tell the difference between the two. Patient-initiated, time-initiated, machine-initiated. Watch what happens right here. Look at this area right here. You see that dip down right there? That deflection in the baseline says, hey, the patient attempted to take a breath, but there was no breath that happened. Let's look at it again. Let's look at it like this. Here, the patient tried to initiate a breath. There's a dip in the pressure waveform. How did that happen? Because the diaphragm dropped. But look, there was no breath that came and resulted from it. Here, we see the diaphragm dropped and a breath was initiated. So when you see a dip in the baseline without a subsequent breath, then you know you are looking at a situation where there is a failure to trigger. There is a failure for the ventilator to recognize that the patient is trying to initiate a breath. So we need to adjust our sensitivity. This sensitivity is not set correctly for this patient. We need to make it easier so that when they try to take a breath, the ventilator responds. That's what you need to know. Now, let's look at some questions here. That's the basics of the pressure waveform. Let's do a little practice question here. We got 2 of them. We'll see what you have here. Pause this if you need to. Answer the question, and then come back and restart it. I'm just going to keep going through this. You are caring for a patient whose pressure values have changed from the 0700 assessment to the 10 o'clock assessment. What do you suspect to be the problem? Well, let's look at this. 0700 is here. 10 o'clock is here. 3 hours difference. What do we notice? Well, look, our PEEP here is the same. So we have positive index pressure. PEEP's not going to change unless we change it. Okay, so PEEP is the same. Our plateau pressures have not changed. Now that right there is a big clue, because that tells you, remember, plateau is an indicator of alveolar compliance. If your plateau pressure doesn't change, then you haven't had a change in alveolar compliance. Key point. But look at our PIP. Our PIP has gone up significantly. Now, when you look at this, you go, okay, well, the difference here is 4, and now 3 hours later, the difference is 22. Let me show you what this looks like. Remember our pressure waveform? We started here, and now we're here. Big difference, 22. Here, 4. Plug the other numbers in. 20, 20, 42, 24. Perfect. 8, 8, 8. Perfect. What did I say? If there's a big difference here, then you have an airway resistance problem. Greater than 10 during mechanical ventilation is an indication of increased airway resistance that you need to seek a solution for and to treat. Check this out. What are our options? Is it a pneumothorax? Is it ARDS? Is it bronchospasm? Or is it ventilator-associated pneumonia? Only one of these are related to airway resistance, and that is bronchospasm. Pneumothorax, ARDS, and ventilator-associated pneumonia are all parenchymal problems. They would not present like this, okay? They would not present like this. So what would they present like? Well, let's look. All right, so same scenario, different numbers. You're caring for a patient whose pressure values have changed from the 0700 hour assessment to the 10 o'clock hour assessment. What do you suspect to be the problem? Well, let's break these down. Let's see what is the problem. So we look at our peak inspiratory pressure. We see that it has gone up. We look at our plateau pressure and it has gone up. Now that right there is probably enough to know the answer to this question. If your plateau pressure changes significantly, you have a parenchymal problem. We already know that. So is what it is. Our PEEP stays the same. Why? Because we're controlling PEEP. Got it. Okay. So let's just take a second here and let's just draw this out. When you get these questions, just draw them out. Ask yourself, what's the difference? Oh, it's 4. What's the difference? Oh, it's 4. Oh, so the difference between PIP and plateau has remained the same. That means that our PIP has gone up because our plateau has gone up. We have a parenchymal problem here. We're going to see that here in just a second. So we start like this, and 3 hours later we're like this. Okay, so this is 24, this is 20, this is 42, this is 38. We have a difference of 4. We have a difference of 4. This is not the problem. We do not have an airway resistance problem, right? So think about it. Who's paying attention here, right? If we do not have an airway resistance problem, then excessive secretions, bronchospasm, any of our airway disease processes are out of the equation. We are now looking at a parenchymal problem, an alveolar static compliance reduction. With something is causing our lungs to not be compliant. Okay, now let's look at it. Pneumothorax seems like a potential good answer. We'll hold it in our back pocket to see if that's the right answer. Excessive secretions. Nope, because excessive secretions equal airway resistance. Bronchospasm. Nope, because bronchospasm is airway resistance, and we will see an increasing gap between our PIP and our plateau. We don't see that. PIP and plateau difference has remained the same. So it's not a difference. It's not an airway resistance problem. Emphysema. Now, you're going to see this question come in here a lot, or this answer, emphysema. And you're going to think, well, it just seems like this is the right answer because they're going to test me a lot over emphysema. But not always. Emphysema is actually an increased compliance and has a component of airway resistance. That's not what's happening here. We don't have an increased compliance. We have a decreasing compliance. That's not emphysema. We don't have an airway resistance problem. That's not emphysema. So it's not emphysema, and the answer here is that we have a sudden change in our parenchymal compliance. Pneumothorax is the best answer, and that is what is going on. And now we need to know how to treat that, right? You may see tracheal deviation to the opposite side. We need to know, okay, tracheal deviation to the opposite side, pressure values that are supporting a parenchymal problem, subcutaneous emphysema noted on the affected side. We need to needle decompress this patient on the side where we suspect the pneumothorax. That's how you use the pressure waveform to identify and distinguish between airway resistance problems and static compliance or alveolar compliance problems. Okay? Now, if all that makes sense, then fantastic. I would love for you to follow me at all of the socials, Instagram, TikTok, at Respiratory Coach, Twitter, at Coach RRT. Hey, I'm going to tell you a secret right now. Send me an email to respiratorycoach@gmail.com. I have a waveforms and loops cheat sheet that I would like to send you. All you have to do is ask for it. Send me an email right there, respiratorycoach@gmail.com. And then join my texting platform, 817-968-7035, where I occasionally send out inspirational, educational, motivational material just to connect and collaborate and enhance this field and bring us all together as respiratory therapists. I'd love for you to join that. That's the pressure waveform. This is where you can find me. Remember, average is easy. Don't be it.